present Dr. Luis Godoy, one of our newest faculty members, although not at all new to UC Davis. It's kind of neck and neck with Dr. Wisner for, so we'll have to see at the end of your career whether you beat him out for life lived at UC Davis. But we are really thrilled to have you, and I know the important topic that you're about to talk about, and I just really want to congratulate you on helping our department raise its awareness of and its action, not just its awareness, on all of these important issues. So, Dr. Godoy,
great, thank
take
you.
It away.
Thank you all for being here today and listening on this important topic. As you can see, our M&M conferences are very thorough, and those cases all deserve the time that is required to identify areas for room for improvement. One additional aspect, I titled my presentation "Cultural Complications" and is there any room for improvement? Because I know this is a topic that's hot in the press and in programs throughout the country. People are learning or actually moving towards how do you improve cultural competence in academic medicine. Before I get into the main topic, I'm going to move on to this slide here. So the COVID vaccine is coming. It's on its way. We must hold steady. Help is on the way. This is how I can imagine healthcare workers throughout the country are feeling like right now. So we know that everybody in this room is excited that the COVID vaccine is on its way. However, when we look at the mainstream, we see that that's not true for everybody. So these are actually just from this past weekend that I was reading the news and looking at articles, and I was taking a look at these articles in Los Angeles specifically because they tend to publish a lot of on this particular topic, and it's showing that underrepresented minorities are at an increased risk not only for COVID but also for mortality and hospitalization due to COVID. Then there's this one particular article where they ask, why won't African Americans, why won't blacks trust us on COVID-19? This article goes into details on that. Same thing, if you look at there's two articles here that have the word trust in them, and why is it that these particular communities aren't trusting the healthcare institutions? So what drives this mistrust? Is it lack of education? Is it ignorance? Is it skepticism? What is it that tends to drive these? That's going to lead into my overall discussion. So I'll move on to my disclosures. I have no financial disclosures. A couple of months ago, Dr. Ruth Shim gave a grand rounds, which was called Dismantling Structural Racism in Medicine, Challenges and Opportunities. And as part of her grand round, she gave this very important disclosure or disclaimer that I will borrow from her. And in it, she stated that these topics are definitely difficult and uncomfortable to cover. People have complex feelings that are brought up, including guilt, anger, resentment, defensiveness. There's the perception of accusations of racism, sexism, etc. But just to remind everybody, there's no, this is a safe environment for everybody. There's no political agenda. This is just a fact that we've all been conditioned to believe that discussion on race and racism, that it's not polite to discuss those issues. So why does this all matter? So why is this important? So every day that we move along, America becomes more and more diverse. This slide here represents the census data from 2017, which was the most recent one prior to the current census that's ongoing. And in it, they described how 40% of Americans at that point in time considered themselves to be an ethnic minority. But then when you look at the younger age groups, you see in these colored bars here that approximately 50% of the younger population considers themselves an ethnic minority. So what that does is it foreshadows and it really paints the picture that as the population continues to age in the United States, the population is going to continue to become more and more diverse. And as this happens, these patients will interact with multiple individuals as they seek medical care, and they're going to interact with doctors and nurses and students, all of whom have both implicit and explicit biases that can influence patient care. There's been many reports, as you all know, that show and have documented how healthcare outcomes are adversely affected with implicit and extrinsic biases. Sorry. And then these biases can influence the decision making of both the healthcare provider, can influence the patient's overall perception, and can aggravate healthcare disparities and overall aggravate the patient-physician mistrust. So here's just a brief context of why this mistrust is so firmly ingrained in current society. So this particular slide was this article was published in May when they were enrolling people for the COVID vaccine trial, and this lady Jacqueline Temple was asked about her decision to participate. And in it, she describes that when she was asked to participate, the first thing that came to her mind was the Tuskegee, what she calls the Tuskegee moment. And so every time that she thought about experimental or the we want to study you or there's no cure but we can treat you, Tuskegee is on the back of her mind. Ultimately, she went on to participate with the study. But these comments are not unique to her. So as we can see, there's common African American patient statements stating that they don't want to be a guinea pig, or that, and flat out, they don't trust doctors. There's no surprise with these underlying themes here why clinical trials lack the numbers of minorities. Because of these so well ingrained and handed down stories. In Spanish, for example, the term clinical trial translates to ensayo clínico, ensayo meaning like practice, like you go out and practice baseball, you go out and practice dancing, or that's what it literally means. So it doesn't surprise anybody why these numbers are lacking. This is another powerful picture here that I wanted to put out. Does anybody know who this James Marion Sims is by any chance? So this painting was commissioned in his honor. He's revered as the father of modern gynecology. He's an American surgeon who perfected his surgical techniques by operating on enslaved black women without anesthesia, because he believed that black women could not feel pain. He went off to perfect this technique. Then once his techniques were perfected, he went to Europe and offered his procedures to wealthy people in Europe with anesthesia. And this painting, until recently, used to hang in the state capitol of Alabama, and it was ultimately removed due to public outcry. This is one of the quotes that when I was reading this article, really stood out as one of the advocates for removing the painting, where they stated that the irony is also in their clothes. Some people, society, look at people's status, respect, based on how one is dressed. The one who should be honored and respected is the one who owns no shoes. So I thought this was a very powerful image, and it really says a lot as to how people nowadays view the overall culture and the history of medicine. Many of us, and there are many people who say that these days are long gone. Things like these can't happen anymore. For the most part, people are correct in that sense. There's a lot of oversight and regulations and cultural competence that's starting to help improve things. However, there are more subtle forms of aggression towards minority groups that continue to feed them into this mistrust that, again, has been handed down from generation to generation. This slide here, we define the terms of microaggression versus macroaggression. This term microaggression was first coined in 1970 by the Harvard psychiatrist Chester Pierce. And microaggressions, he said, described interactions, whether intentional or not, that convey in subtle but powerful ways negative messages about specific groups of people. They're subtle in the sense that the person who's the source might not even be aware of what they are causing. Macroaggressions, on the other hand, are this is like a whole topic in and of itself. Talks about institutional, structural racism. My main focus is going to be on microaggressions that all of us interact with and are victims of. Sometimes we're the sources, sometimes we're observers on a day-to-day basis. These often affect the morale of students, trainees, faculty. Ultimately, these microaggressions lead to a negative impact on patient health and patient outcomes. Here, Dr. Daryl Wing Su from Columbia subcategorized the microaggressions into 3 different categories. So from the most obvious to the most subtle. So a micro assault can actually be an actual assault, derogatory comments directed at somebody, overt sexual harassment. There's micro insults, which can be termed like backhanded compliments. For example, there's a comment or a quote from Joe Biden recently that made the media, where he mentioned that he complimented President Obama by calling him the first black person articulate enough to be the front runner for president. Now, he meant that as a compliment, but you can see when we look at it from a different perspective that it's considered a micro insult. And then there are micro invalidations where, if, say, for example, you're telling somebody about a microaggression that you just were part of or you were a victim of, and people are just telling you that you're too sensitive, you got to learn, you got to grow tougher skin. So this kind of sheds the light on not the person who's the source of the microaggression, but you as the receiver. So here's another good example. This is a micro assault. And again, I was reading a lot this weekend. Did you guys all see this article in the Wall Street Journal? So this is an article. It's an opinion piece. It made the media, and there was like a Twitter storm and the Facebook storm where this, if you look at the title, is there a doctor in the White House? Not if you need an MD. And then the first opening sentence of this piece, we'll read it here. It says, Madam First Lady, Miss Biden, Jill, Kiddo. So you can see it progressively gets more and more condescending and derogatory. And when we go back to the end of this quote here, he asked her to drop the doctor before her name because Dr. Jill Biden sounds and feels fraudulent, not to say a touch comedic. Well, she has a master's, PhD in education, so she's earned that degree and she's earned the right to be called doctor, to have that as part of her title. People didn't really, you can imagine this is a very misogynistic type of article that was written. People didn't receive it well, and there was a definite outcry from folks. Here saying how every single woman in academia can relate to something like this. You have this Dr. Jill Biden being called kiddo and being pretty much brought down and stripped of her qualifications. And then she replied with a very classy response, which I've posted here. So how did the Wall Street Journal react to all of this criticism? So the editor wrote back with this, and he says that there's nothing like playing the race or gender card to stifle criticism. And so they said that they were going to continue to post these articles. So why are these microaggressions a problem? So one is they've been shown to have a dose-response relationship with both depression and anxiety. We all know that chronic stress increases allostatic load, which is also associated with physical health problems like cardiovascular disease, diabetes, and obesity. As you can imagine, people who undergo microaggressions on the day-to-day can potentially have a constant fight or flight type of response, and we know the deleterious effects of adrenaline and cortisol and what those effects have on health. They perpetuate stereotypes, passively allow society to devalue groups. And then there's a cognitive overload. I put an asterisk here because as learners and as trainees, this is where if you experience one of these microaggressions, you start to divert your energy, not from learning and your academics or your patient care, and you start to focus on like, wow, like, did that just really happen to me? I remember an example where I was taking care of a patient in one of the ICU rooms, and the nurse came in and started yelling at me for discussing patient care with the patient whom I was pre-oping. And the nurse came in and said, I'm going to report you for discussing medical care with the patient. And I asked why. I mean, as a disclaimer, I was wearing one of those like C. diff type of gowns on, and when I took my gown off and the nurse saw my badge that I was a physician, he pretty much stopped in his tracks, and then he turned and looked at the door, and there was a janitor's cart out in front of the room, so he thought I was the janitor who was discussing the patient's surgical care with the patient. And so when my focus at that moment should be on the patient and the procedure we're going to do and the next step and honing those details, for the rest of the day, I was thinking like, wow, did that really just happen? Like what I started rationalizing things, and it really distracted me for the rest of the day. And this can happen to trainees and to faculty and to just people in general. And then, to tie back to that opening slide, in healthcare, microaggressions can lead to patients losing trust. It can lead to delay and foregoing of medical care. This is an example of a friend of mine who is an emergency room physician. She's a female, and on the constantly daily basis, she'll go in and see a patient, and the patients call her honey, they call her sweetie. They say, oh, when's the real doctor coming in? When's the doctor coming in? And even though she explains to them that she is the doctor, she'll spend time here. She spent several minutes explaining that she was the doctor. The patient then at the end asks, like, when's the doctor coming in? So you can see how that can kind of build over the course of one's daily interactions. This is from one of our great ICU nurses whom I've had the pleasure of working with. She's very talented, very humble. She treats her patients very well. But this was a very powerful post that she put, because she puts that she woke up in tears, literally thinking of retiring. She was saying it's seriously hard for her as a black woman to stay in this position after yesterday. And she says in her time at the university hospital, she's loved every single minute of it, learning, working with the best, and becoming a better nurse. But her experience in one day literally erased all of the 10 years of it. Microaggressions are racist, period, and I wish people understood the toll that it takes on a person. So I thought that was a very powerful message. And again, this is not historical. This is just recently. This is a couple of weeks ago that I came across this. Again, in the media, this article came up. This is actually a friend of mine. He's one of my upperclassmen who's an emergency room doctor who practices here in Sacramento. And then he wrote this article that was published in the Washington Post, where he describes this scenario as a Jewish man who is taking care of a patient who comes into the emergency room in distress. They strip the patient's clothes off and they see swastikas and SS and lightning bolt tattoos. And he describes that internal conflict that he has. And I think he gives himself a very honest assessment of this whole experience. In it here, he describes all of this being a team that included a Jewish physician, a black nurse, Asian respiratory therapist. They all saw the symbols of hate on his body, outwardly and proudly announcing his views. We all knew what he thought of us. And then so he then starts to question about what if these roles were reversed? Would this person try to save my life if shoes, if the roles were opposite? He goes on, he runs through the plan with the team. He pauses. He says, I see the tattoos and wonder what he might think of a Jewish physician taking care of him now, or how much he would care about saving my life. For the first time in my career, I recognize that I hesitate, ambivalent. The pandemic has worn on me. My mantra of caring for all isn't having the same impact in the moment. I realize that I may not be okay. So these are where the lines can be blurred. This is where patient care can suffer. He honestly becomes aware of this internal conflict and expresses it. This was met with some public outcry based on the commentary that was received. However, it's important to take note that in this particular scenario, he actually switches role, one from being the recipient, from seeing these derogatory markings, to being the actual source, because he starts to question what he should do for this patient. And so there's a degree of hesitation there in him as a provider that can ultimately lead to patient harm. So the question is, we always see this fishbone structure every M&M. We saw it today multiple times. Can we use this structure to, when there are complications or cases that we can identify, can we use this structure to ultimately break down the root cause for these what are termed cultural complications? We talk about some individual factors, implicit biases, explicit biases, team factors. Have you witnessed something going on with your team, how a patient is cared for? Have you witnessed good examples of patient care? Patient factors, the mistrust in the system, like we mentioned. How about patient factors on the flip side? How about when the patient is the aggressor? Have you ever been into a patient room and had the patient yell at you for being late to repair the air conditioner, or the patient asking you, where are you from? And you tell them, and they're like, well, no, originally, like, where are you born? Where did you do your training? And or one expression that I heard was, I'm glad Trump is gonna take care of people like you, like just overt things like that, which are very difficult to deal with. And then ultimately environmental and resources. Do we have the resources are there any flaws or breakdowns in these that can lead to cultural complications? Rules, policy, and of course organizational. These are some of these are the more structural type of things that are a little bit challenging to ultimately change, but little by little, changes can be made. So there's this cultural complications curriculum that was, I attended a webinar. This was developed by the University of Michigan and University of Maryland, the departments of surgery there. And so in it, they have several modules. There are about 15 to 20 minute presentations that they present during M&M conferences, actually. They dedicate some time for these discussions. They have 12 core themes in diversity, equity, and inclusion. It's driven by students, residents, and faculty, personal experience, and ultimately participation. These are some of the core topics. I won't read them all out loud. We'll visit some of these later on as part of the curriculum that we plan on instituting here as well. But in it, they have some standard case presentations that they've developed along with the literature and definitions, and they do it in an evidence-based way. This is a sample scenario. So a patient complains to the female chief resident that he hasn't seen a doctor in 5 days despite her rounding on him every day. We go on into the why this is a micro insult, issues to discuss, and then at the same time they provide additional reading and sources for people to look at. This is another excellent example from the pediatrics hospital, children in Boston. And they published this paper in the AMC Journal of Teaching and Learning Resources, Health Equity. They call it Health Equity Rounds. And what they do is they also present specific cases. In this case, they're more student-run, resident-run, trainee-run. So experiences that people see, and then they discuss these cases as a group during their teaching conferences. Again, this is from the pediatrics literature, so it's not during M&M conferences or any. These are mainly due to during the teaching conferences. In it, they note that there's few curricula that engage both faculty as learners rather than teachers, and this is one of the reasons why they decided to do this during one of their teaching conferences. These are some of their goals that they describe. So they want to identify and analyze the effects of implicit bias and structural racism in clinical scenarios. They want to describe the historical context and present-day role of structural racism and the impact on the healthcare system. And then they want to employ, this is the important part, of evidence-based tools to recognize and mitigate the effects of personally held implicit biases. The way that they did it is they use this longitudinal case conference that they have to implement their curriculum to discuss these issues. They engaged participants across trainee levels, and they also did it in a multidisciplinary approach where they had also nurses, NPs, and other people as well discussing these topics. This was delivered quarterly as part of their department case conference series, and the feasibility and acceptability was assessed by tracking conference attendance and administering post-conference surveys. They analyzed the quantitative survey data using descriptive statistics and qualitatively reviewed free text comments. This ultimately was developed. It was resident driven. They developed it. It was developed by a small group of residents. It was meant to meaningfully bring trainees and faculty together to discuss these difficult topics. Trainee leadership is extremely key in this for both content and sustainability. The team's composed of residents at different levels in training, and also advisory teams of faculty members who provided feedback on case selections and topics. When they reviewed their outcomes after they analyzed the data for these 2 years that they had implemented these conferences, they overwhelmingly saw positive results with, as we can see, close to 100, above 90% of people here thought that the conference was excellent or good. and with the majority of people saying that these conferences would ultimately affect their overall and improve their overall patient care and their clinical practice. So how are we going to do that at UC Davis? So one, I'm going to be partnering with our institutional chapter of socially responsible surgery. These are some of our resident leaders who are in that group, and this is one of their goals here is to improve surgical equity and patient outcomes. They, as part of it, through research and implementing these cutting-edge ideas and educational studies to advocate for the surgically needy in Northern California. I'm planning on having more of a hybrid approach from these two programs that I discussed. One is, as you can see, time is limited during M&Ms, and realistically, spending 20 minutes on a case during M&Ms can really take away from that part of the educational experience. So we're hoping on doing some brief presentations, maybe 10 minutes to discuss a scenario on particular topics, and then space them out throughout the year, utilizing that guideline from the University of Michigan and their core topics and their core literature base that they have. And we also anticipate on having these brief post-session surveys that would be anonymous. Again, so a lot of the times it's a commentary that can be quite interesting at the end of these thought-provoking sessions. And then we want to provide tools and resources to address these microaggressions. I'll lead off, this, or just give you guys a tidbit here. There's what's called a triangle model, where you address these by approaching these microaggressions from three different standpoints. One as the recipient, one as the observer, and one as the source. And so we'll go over some of that as part of our curriculum as well. And then we encourage medical students, trainee, and faculty participation in these endeavors, because ultimately I think it's going to help us all grow as people. Again, it's not meant to be, point the finger at anybody or any particular group. This is just more to have a safe space to discuss these important issues to ultimately address them. So with that being said, I want to thank you all. I know I kind of breezed through these in order to give some time for discussion if needed. We're limited on time.
I just want to say thank you you may be junior as a new faculty member, but you are mature and long in life. And so we appreciate the wisdom and the courage that you bring to these important conversations. Sacramento's a place that should be a leader. As there were many things I thought as you were commenting. One is, which is, why do we not have more, at a minimum, bilingual signage around here? How do we really represent the community that we serve, and how do we do things to message in many ways, things we could do better. I think there's a lot that we can do better as soon as we put our minds to it. So I really look forward, and I appreciate the effort that you put into developing a curriculum for our department and partnering with our great leaders for whom this is really front and center. So thank you.
Thank you.
Questions from the audience or the virtual audience? Manny, Elizabeth, that looks like you were, while Manny's mining the chat.
I just want to echo Dr. Farmer's sentiment. I mean, this was an incredible conversation, and I can tell it takes a lot of bravery to kind of express the things that you've experienced. And I know that there are many people that go silent and don't share these things that have happened to them in their career. And it's so important that we talk about this, ranging from, some of us who come from different religious backgrounds to, from different countries that they're from or their families are from. we don't have these conversations enough. And I'm really impressed with your talk, and I hope to collaborate with you in your endeavors because I think this is such important work. So congratulations on a wonderful
Thank you.
talk.
Thank you.
And I do think we're going to make time to make this happen for the department in M&M, so we can do it as a department and transition perhaps how we do some of our department quality.
Great. Wonderful work, Dr. Godoy, and I think really important and fascinating concepts. And I really appreciated your discussion on how, your points on how these discussions are uncomfortable for people to talk about, not just for people who may undergo microaggressions or for our patients who undergo sort of cultural insults, but just, from everyone, no one likes to talk about politics, no one likes to talk about religion, and in regards to race and historical racism, these are difficult conversations. That's why I like your concept of incorporating this intervention into sort of everyday life of our academic department. So instead of having sort of a separate standalone cultural competency M&M that's on, 2 p.m. with some coffee and 3 people show up, all of whom are already culturally competent. You have it interwoven within the natural framework and everyday activities of the department, specifically M&Ms. So that way you're kind of normalizing these discussions, and over time it becomes easier and more comfortable for people to talk about and incorporate into their daily thinking. Like if I'm going to go, if come January 1st I make my resolution to get fit, I'm not going to start off with like 50 push-ups every day. I'll start off with a certain 10 and then work my way up. So I'm at like 15 by the end of the year. So I applaud you for your approach to this.
Thank you.
Yeah, I'll just take a minute to say that certainly when I was going through training, which is now a long time ago, we were explicitly taught to not bring up any of these issues if you wanted to succeed, as a female at the time. And I think I've told this story before. There were 5 women in my medical school class, and then the first year, the professor all said, "Okay, take off your shirts. We're going to do history and physical and learn how to listen to hearts." So the 5 of us women all looked at each other, and we didn't know what to do, and we all took our shirts off. The story I don't usually tell in public, but Lisa.
We come away, so we have a little bit, and I'm well beyond 10 push-ups. I was going to say,
That could have been
Luis, that was a phenomenal talk. Great examples. I saw those examples as they were coming through in real time. And I guess my question is, when I think about these things, it's real, right? So here's the thing. The example that you gave about the editor of the Washington Post.
Wall Street
Wall Street
Journal.
saying, actually standing up for and saying the race card, the gender card. How do you think we can, are there ways that have been shown to get through to people who don't get it? Because I'll tell you, I've always kind of thought I got it until I experienced it in fellowship. And then it was in my face, you're a second-class citizen in CT surgery. So that changed my perspective on a lot of things. Is there a way to measure and try to figure out where people are at, or how do you change the minds of those people or get through to them?
Yeah, if I knew the answer to that, I'd be giving a whole different talk altogether. But yeah, it's very 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 challenging, and one of the ways that people, especially with some of these, when I've looked at some of the survey results from these particular programs, were the gradual discussion over time. Overall, the most important thing is trying to get somebody to like empathize or put themselves in someone else's shoes and look at things from a different angle. This is where this triangle model here, that's a little bit of a teaser, kind of comes into play, because it kind of makes that person look at things from different angles and picture themselves as a person receiving these micro or macroaggressions. But it is something that takes time. Over the course of these 2 years, some of their feedback were, that they opened their eyes and they hadn't realized what things were going on, and ultimately they decided to change their overall outlook, or actually caught themselves practicing these types of interventions internally, whereas before they would have just moved along. So it's challenging.
Megan first and then.
Very excited for the cultural competency coming up. Do you have any specific resources, websites, books that you would suggest for people to learn more about this?
Yeah, so so this book by Sue is really good. It's this one here. I'm sorry, just breezed right past it. Microaggressions in everyday life. It's the reason why I decided to look into this in particular is because it's cited amongst the literature, and he really goes in and breaks things down in day-to-day language without being accusatory or it's very readable. It's a really good book in that sense. I think that's a really good resource to have.
All commit to trying to have it be one of our holiday reading items.
Yeah, and then as part of the curriculum, rather than giving everybody one long list of resources, we'll add resources throughout the curriculum as well.
So that our program doesn't turn into Dr. Cook's exercise plan. Mandy.
Dr. Niles Young says, "This is a great discussion. How do you deal with counsel your own children relative to these issues?"
I'm sorry, how do you
counsel your own children relative to these
okay. Yeah,
issues?
this
Leave it
is...
to Dr. Young to ask the probing, difficult questions.
Again, it's something that has a lot of historical background. So the way that I counsel my children in particular is different than the way other people might counsel their children, just because I come from a different background than other people may say. So, for example, I teach my children certain things coming from a underrepresented background. For example, one thing that I tell my son is, if you get pulled over by the police, hands on the wheel, yes sir, no sir. Don't make any, like things like that other people don't necessarily have to go out of their way to teach their kids those things. In the overall context, the overall scheme of things, from what Dr. Young is overall leading to, I think it's just a matter of leading by example. So if your children at home are seeing certain things or see certain comments or hear certain comments, ultimately I think they pick up on those things. So I mean, there's pictures that you'll see, when I was doing my reading on this particular topic, you see pictures all the time where you have two infants, African American, one white, and they're playing with each other, and it says, that racism isn't, you're not born with it, it's kind of a learned type of thing. So, ultimately I think leading by example and having these frank discussions with your children are important.
I think on that spectacular note, we'll end the morning, but this is the beginning of a new era for our department. So thank you very much, Dr. Godoy.
Thank you.